I'd like to start today's webinar with an acknowledgement of country. The Kids Research Institute Australia and the University of Sydney acknowledge the Aboriginal and Torres Strait Islander people as the traditional custodians of the land and waters of Australia. We honour the Whadjuk Noongar people and the Gadigal people of the Eora Nation, the first peoples of the lands on which our institutions are located, and pay our respects to elders past and present. As colleagues and attendees join us from many different places, we extend this acknowledgement to all First Nations people, recognising the strength of their knowledge and the continuity of their cultures, stories and connection to country. I would like to welcome to the stage Professor Elliott.
Thanks very much, Leah, and welcome everyone to the FASD Hub Australia's webinar, in which we'll explore the relationship between fetal alcohol spectrum disorder, autism spectrum disorder, and attention deficit hyperactivity disorder. And we may use the abbreviations FASD, ASD, and ADHD. My name is Elizabeth Elliott. I'm a Professor of Paediatrics and Child Health at the University of Sydney and a consultant paediatrician at the Sydney Children's Hospital Network, based at Westmead, where I head the New South Wales FASD Assessment Service. As Leah said, I'm also the project lead and chair of the FASD Hub Advisory Board. The FASD Hub was founded by the Australian Government Department of Health, Disability and Ageing in 2016 under their drug and alcohol program. It aims to raise awareness of fetal alcohol spectrum disorder and alcohol use in pregnancy, and to be a one-stop shop of evidence-based resources, particularly for clinicians, policymakers and researchers. The Hub connects clinicians with researchers and policymakers and with individuals and families who are living with fetal alcohol spectrum disorder. We run educational webinars such as this one, provide a directory of FASD-informed services and a repository for Australian research and policy. Now, just to set the scene, what do we know about fetal alcohol spectrum disorder in Australia? Well, FASD is increasingly recognised, and recent estimates suggest that the prevalence is about 3.6 per 100 children, 3.6%, or one child in every classroom. Fetal alcohol spectrum disorder is a complex neurodevelopmental disorder caused by prenatal alcohol exposure and associated with significant functional impairment, spanning skills that are essential for school, work, and for negotiating daily life. These include cognitive function, communication, attention, memory, and social skills. But individuals living with fetal alcohol spectrum disorder may also experience physical problems, organic diseases, and mental health disorders, such as anxiety, depression, conduct and attachment disorders, autism, and ADHD. We have a national database, and our national Australian data from over 1,500 children diagnosed with FASD by paediatricians show that 71% have a diagnosis of ADHD and 26% have a diagnosis of autism. But one of the biggest challenges we face as clinicians is disentangling these various conditions that may coexist with FASD and developing an effective response to management. So today's webinar is intended to address these challenges. It will be a conversation between me and Professor Raja Mukherjee to explore this complex relationship between FASD, ASD, and ADHD. And this will be followed by a Q&A. So please put any questions you have for Raja into the chat for curating by our moderator. And now, before we proceed, I'd like to introduce our guest speaker. I'm delighted to welcome Raja, who is both a friend and a colleague, and is joining us today from the United Kingdom. Raja, would you please join me on stage? And Leah, you could move the slide on. So, Raja, just waiting for him to join. Ah, there you are. Appeared from the other side of the world. So Raja is a psychiatrist with an interest in the management of developmental disorders across the lifespan. He's a consultant psychiatrist in adult learning disorder for the Surrey and Borders Partnership NHS Foundation Trust, and he's clinical lead for adult neurodevelopmental services, including ASD and FASD. He is also professor and lead for psychiatry at the University of Surrey and an honorary professor at the University of Salford. In September 2009, Raja started the first NHS-based specialist FASD clinic, which has become a national referral service. And he's provided secondary specialist opinion for over 500 cases. Professor Mukherjee has advised the British Medical Association, the UK Department of Health, the World Organisation on FASD. And in 2015, he gave evidence to the first all-party parliamentary group on FASD at the House of Commons in London. He's a member of the NICE Quality Standards Group for FASD, which develop clinical practice guidelines. And he is the only UK representative to an initiative to consider the research criteria for FASD initiated by the National Institutes of Health in the USA. He was awarded an MBE, a Member of the British Empire, for his work related to FASD in the King's Birthday Honours List in June 2023. Welcome, Raja, and I think it's a testament to your reputation that we've had so many people joining us today.
Thanks, Liz.
We have the next slide, please. So, Raja, really before we start, just to set the scene, can you remind us, what are the diagnostic criteria used for FASD in the UK? I believe the criteria are very similar to those used in Australia.
Yeah, the criteria are very similar to what you have in Australia. We use the SIGN guidance, the Scottish Intercollegiate Guidance Network, 156 guidance. And that was based very much on the 2016 Canadian guidance. It was a Scottish review, and because Scotland is one of the 4 nations of the UK, they are part of the general consensus, so there was no point NICE doing the same thing, and so we adopted the SIGN guidance and used them here. The only difference is the NICE quality standards, which the committee that you mentioned I'm on, then put audit reminders in for the local countries to say what they expect people to do. So that's where that side comes. But we use pretty much the same approach that you do.
Okay, so we're looking for prenatal alcohol exposure. We're looking for significant functional neurodevelopmental problems.
Exactly.
And then we're documenting the growth, head circumference, and facial features. Great.
Exactly that.
So Raj, could you start by defining for us what is autism? How is it screened and diagnosed? Who should do this, and how is it classified?
So autism is a condition where there are difficulties the individual faces with social communication and restrictive patterns of behavior. If we go back historically to 1943, when Leo Kanner first described it, we talk more about a triad, but in the most recent iteration of the diagnostic manuals, we've moved to the two broad components. And so we focus on a mixture of social communication and restrictive patterns of behavior. And somebody who presents with these in a pervasive manner, i.e. something that's there all the time to a certain degree. It's not something you can have in one situation and be fine the next day. It's something that is there all the time. This is the thing about all neurodevelopmental disorders. I think that sometimes people miss is it's not an episodic condition. It's not like depression, which comes and goes. It is there all the time. And it's something that starts in early childhood and during that early developmental period and continues. And again, you can have people later in life, for example, people with dementia, where you've got damage to brain pathways can present in a similar way, but that's a degenerative condition. These are neurodevelopmental conditions where you have the two broad areas affected.
Thanks. So in your practice, who usually screens and diagnoses autism?
So it's a mixture of people, but I think the important factor for all of these situations is unless it is part of your core training, you have to develop the competencies to become an expert in the area. And so I had to do lots of extra training, go away, learn about things after my general psychiatry training to become an expert in this area. And it's the same for anybody, is you need to go and develop those skill sets. So now we have a mixture of backgrounds who are working in our service, from nurses to occupational therapists, speech and language therapists, so a range of people, including psychiatrists, pediatricians, and medical doctors who have trained to do it. But the important thing is you have to have the competence to do it.
Great, thanks. And do you use the DSM classification usually?
Yeah, a mixture of ICD and DSM. ICD-10 is getting a bit out of date, but we've moved to ICD-11 now. And so we tend to use the criteria as defined in DSM because it's more clear cut in terms of cutoffs and definitions. But because in the UK, our registration, our coding is done through ICD, we've moved to then link that to an ICD diagnosis.
And as we all know, autism can occur along a spectrum with various degrees of severity. Would you like to make any comment on that?
Yeah, I think the key, as I kind of alluded to in my first answer, is it has to be there all the time. It has to cause a level of impairment. Impairment is something that is in the diagnostic criteria, and we all have a degree of rigidity at times. We all have a degree of difficulty in social engagement at times, and that normal variation shouldn't be pathologized. And so this is defining to get a disorder diagnosis rather than just being somebody who's got a difficulty, is something where you have to have it to a more extreme degree. And this is where there's a little bit of misunderstanding out in the internet ether that exists, that effectively just because you have things now and again and it's difficulty doesn't mean that you've got autism. It doesn't mean you have ADHD. These are things that are much more persistent, cause a significant level of disability to those who are really affected, and then still meet the criteria in all situations.
Thanks, Raja. Now we might move on to ADHD. I guess the same thing. How do you define ADHD? How do you test for it? And how do you classify it?
So ADHD is a condition of attention, hyperactivity, and impulsivity. They're the three core components that link to it. And we're looking for that through, as with all of these, it's a combination of observation, direct watching, and history that you take. That's the skill of it. And then what we do with all of these diagnoses is triangulate the information we collect, whether that's from objective measures, whether it's from the direct assessment, whether it's from the history. We collate that together, and then we come to a diagnostic conclusion. There aren't specific tests that we can do. For example, with COVID, we had PCR tests which said you have it or you don't have it. We don't have anything like that. So it's about the rigorous evaluation of the individual to come to that diagnostic conclusion.
Thanks, Raja. So we know that there's a significant overlap between a whole range of neurodevelopmental disorders, not least between fetal alcohol spectrum disorder, autism, and ADHD. Would you like to comment about this interrelationship?
Yeah, so my journey with this all started because of this exact question. And so back in 2002, I went to a conference where Christine Locke, who you know, was speaking, and I left there saying, well, why isn't this autism and ADHD? Because that's what it sounded like to me as somebody working more in that area than FASD at the time. And what we came to understand is autism and ADHD are outcomes of neurological pathways being affected. FASD is one of those things that cause damage to those pathways. It is what we call an etiological, a causative disorder. And so you're comparing it to other genetic conditions, prematurity, other things like that, which are known to cause damage to body and brain, because that's what it's doing. And so the prenatal alcohol is the risk factor, but not everybody who has alcohol exposure goes on to have FASD. The putative risk factor then leads to the condition we have defined as FASD. You've helped define it in Australia. We've got the same definitions all over. And then what we then say is, if you have FASD, what are we likely to see? And because FASD can disrupt those pathways in the brain or parts of the body that lead to the types of presentation we've described in the previous questions, it is what we call a causative risk factor. And so the relationship is is cause outcome.
Thanks, Roger. Would you like to comment on the difference in presentation in, say, a child who's neurotypical? The difference, how would they present differently with ADHD compared to if they had FASD as well?
So again, because like I said, autism and ADHD have different causes. There's multiple different causes of autism and ADHD. And all of these things are causing damage to the similar pathways which lead to these conditions we've defined as autism and ADHD, but they'll have differences as well. And so we know that what is the cause will have a different spectrum of presentation. So, for example, somebody who has FASD tends to be pro-social. They lack reciprocity. They can still be quite rigid, because one of the things we know is that alcohol causes damage to midline structures, especially the corpus callosum and some of those central areas. So anything that needs that bilateral, two sides of the brain talking to each other, can be affected. Well, we know that rigidity comes from sometimes that inability of the brain connections to predict what's going to come next, called predictive modeling. And so we can judge that, and we can work out and say that if you have this damage, you're more likely to end up with this kind of scenario. And alcohol causes that kind of presentation. But because we have areas of the brain that are preserved and are function better, you have a different presentation again. A different condition, let's mention something like cornea de Lange, for example, which is a genetic syndrome. You're much more likely to be withdrawn, aloof, not wanting people. So very different to the FASD presentation, but they could both be autistic, or they could both have ADHD, because those pathways which lead to autism and ADHD in the brain are affected. And so you have a different type of autism, a different type of ADHD with somebody who's got FASD as the cause compared to other genetic causes. And trying to pull that apart is what we have to do.
Thanks. We might move on to the next slide, and you've sort of covered this in part, that we know that fetal alcohol spectrum disorder is precipitated by a brain injury due to prenatal alcohol exposure, whereas autism and ADHD are outcome-based conditions with a range of causes. You've sort of touched on this, but would you like to elaborate on, for example, some of the many causes of autism or ADHD?
So the most common cause of any condition is going to be genetic, because genes don't code for conditions. We know that now. What they code for is proteins. They code for pathways. They tell those proteins where to go, and if that coding is wrong, things end up in the wrong place. It's like, I'll give you a very simple example. There's a hospital I worked at called St Helier in South London. It's built the wrong way, because when they had the architect's map, they turned it round and the front of the building faces the back. And so it's getting the map the wrong way round. And so if your coding is wrong, things go to the wrong place. And genetics is what the single biggest thing. But we know alcohol can have an impact on that in two ways. One is epigenetics, where it changes that coding, so it turns the map the wrong way around a bit, so you end up in the wrong place, or direct impact on damaging the thing. So it's like putting a roadblock in and sending something a different way, so they end up in the wrong place. And so alcohol is having an effect in different ways, but ultimately genetics is the single biggest thing that causes that, but there are other things as well. So prematurity, if your brain hasn't developed enough and you're born early, then it doesn't mature in the correct way. It can be other drugs as well. So we know that other drugs can disrupt mechanisms, not necessarily to the same extent as alcohol, and not to the same severity, because they're all biological things that actually have specific influence. And one of the things that we make the mistake about doing when we talk about drugs is think about the social impact of a drug compared to the biological impact. You wouldn't do that with a medicine, for example. If we thought about a medicine and we had to prescribe a medicine in pregnancy, for example, we would be understanding what it did, where it would act, what kind of impacts on it. So say take sodium valproate is probably the most common example that we don't use so much these days, because of what we know it does. But when we talk about other illicit substances, we tend to think about the social impact, but what we should be thinking about is what is a biological impact and how can we understand what it does. But you can see all of these factors then start to have an impact. With postnatal adversity, it's slightly different because it's a compound effect. And I'll show you in later slides that some of the things that shows. But effectively, it's thinking about the wide range of things that can influence it that leads to these outcomes. And autism and ADHD are multifactorial, where there are multiple different causes which are disrupting those pathways. And when we make a diagnosis, we make it based on the symptoms that present. And so that's why we look at trying to triangulate all the information and trying to spend the time being accurate, because you're trying to gather all of this information. There isn't one test that gives you a definitive yes, you have it, or no, you don't. And so the relationship is about cause, outcome, and the symptoms that then present.
Yes, I mean, I understand that there are over 1,000 genes have been implicated in autism. So clearly, you know, having that genetic makeup, it's how that manifests. It depends on the environmental stimuli in that particular individual.
No, absolutely. And the more we get to know, the more we start to understand. Only 2% of the human genome, I understand it's even less now, people think, actually code for proteins. 98% of the proteins, the coding of your genes are to tell those proteins where to go. And so you can start to imagine that, you know, it gets really complicated in terms of the relationship between genes, epigenome, and the phenotype that you see at the end.
Yeah, and I've just come back from the FASD meeting in Seattle. And of course, there's increasing interest in the interplay between prenatal alcohol exposure and other drugs. Fortunately, illicit drug use is not as common in Australia, but is certainly increasing. And the worry in the States is with the legalization of cannabis, that more and more pregnant women are using cannabis in addition to alcohol and other drugs.
No, absolutely. And I think that is part of the challenge that people are starting to understand. Whilst early research was inconclusive about cannabis, there's more data coming out suggesting some of the harms that it can do. And obviously that's the research that is ongoing. From my understanding, the level of THC, tetrahydrocannabinol, rather than the cannabinoid, because there's different parts to cannabis, has a greater impact on the damage. In the same way, you're more likely to develop psychosis if you had a high THC compound than a low THC compound. But people who are buying it illicitly don't know that. And I'll give you another example. I recently went on a weekend away to Amsterdam, and they tell that you can buy different grades with different levels of THC to develop more of a experience, so to speak. And that's dangerous because people don't necessarily think about that. They just think about a compound and not that this has different levels of harm. Again, if this was a medicine, you know, if you were taking paracetamol, for example, or sort of acetaminophen, if in the States, I don't know what you call it over in Australia.
Paracetamol.
Paracetamol. Good.
Panadol.
I'm glad you do get the correct name. But you know, you'd have 250, 500 milligrams. You know that actually this greater strength has more effect, but that's not explicit on this. So people use things without that, and often it's the first step towards other things as well, which is a concern.
Yeah, so I was interested in seeing the preclinical models increasingly being used to look at these interactions between alcohol and other drugs. So, Raja, you know, we've said there are many factors can affect neurodevelopment and can result in either developmental delay or neurodevelopmental impairment in function. How do you sort of tease this out when you're making a diagnosis of FASD?
So FASD is a diagnosis where we have to find the inclusive features, so the things that we expect to see. So we have the different domains that we expect to look at, we measure those, and we say, do you meet the type of profile that you expect? And actually, whilst they say there isn't a unique profile compared to other conditions, there is a fairly expected profile for people who have FASD. Anybody who's seen FASD a lot, you know what to predict, you know what it's going to look like broadly, and so you're looking for that. So that's the inclusive bit. But to be confident that those other things aren't causing it, you have to rule them out. So you look and say, well, was the individual premature? Was there any other conditions? Have we ruled out genetic factors? Can we be confident that there wasn't perinatal trauma, for example, that may have done it? Because these are all things that can cause damage to brain and body as well. And it doesn't mean that alcohol isn't having effect, but to be confident that the primary cause of what you're seeing is the alcohol rather than an additive cause. You have to be confident you can rule these things out. And the reason why that's an important factor is that not everybody who has alcohol exposure goes on to have difficulties. So you have to be confident that the two are related together to make the correlation to say this is absolutely defined and linked to that. And so those are the two parts that we just have to be confident about. So it's a diagnosis of what we call inclusion, but also exclusion.
Yes, and we certainly do go through that process in our clinic of excluding all these other contributors. But also we find that the physical features, microcephaly, sentinel facial features, congenital anomalies and severe growth deficit sort of also help increase the certainty that alcohol was involved in the etiology of the neurodevelopmental problems.
Absolutely. And so all of these point to, especially the biggest thing that we have is the absence of knowledge about the alcohol exposure in utero. And so because you have somebody who comes along, you have a profile and you think it is, but the history is missing. Somebody's been adopted, the history, mother's no longer in the scene, you can't get access to the notes. And those characteristics are what we call pathognomonic. They give you the understanding that this is what is causing it. This is the relationship, and it gives you that real insight to alcohol being the cause, the thing that's there. If you have a very strong alcohol history as well already, to a certain degree, the physical stuff is an additive supportive measure confirming that, but you've got the history already. That we find it the most useful where we don't have that history to help us to confirm that the profile we're seeing is related to what we're identifying. And we're looking at other ways of doing that as well. So you're looking at the epigenome now. There are specific markers that appear to be coming out. There are some work that a PhD student of mine did looking at IRAP, which is a excretion breakdown marker. And it may be that actually in the future we will have a multiple group of testing that we can do, giving a more biological test, which is very definitive, and add that to the wider physical thing that gives us that definitive answer. So we're not just focused on trying to get it through a history.
Yeah, and we find many of our children are actually in foster care, and sometimes that prenatal alcohol exposure is just not available. And just for the audience, that doesn't mean that a full assessment of a child's or adult's strengths and their needs is not worthwhile, whether or not you can reach a diagnosis of fetal alcohol spectrum disorder. From a pragmatic point of view, the assessment is a very valuable tool.
Yeah, I agree.
Okay. So, Raj, would you like to now take us through these next two slides? This is some research that you've done looking at neurodevelopmental outcomes in children with FASD, with and without these sentinel facial features we've been talking about.
Sure. So there's two pieces of research. These are all published pieces. I think they're on your list of handouts that we've looked at to try and look and say, well, actually, what are the relationships between the different components? So what we do in everybody in our service, everybody comes through, we give them the FASD diagnosis, then we say, well, what are the outcomes? And two of the outcomes that we look at regularly are autism and ADHD, because they're the most common ones that we see. And we know that people who are presenting to specialist clinics tend to more likely to have that, because they tend to be the more complex group who are presenting needing wider evaluation. And as a specialist service, that's the kind of people we see. So the rates are probably higher than you would get in the general population. So that's the first thing to bear in mind. But the principle of this is looking at different components to it. So the first one was looking and saying, well, does the having facial features make you more or less likely to have this? And so that's because there was a thought to say, well, actually, if you have facial features, it's more severe, and if you don't have facial features, it's a milder presentation. That's not true. What you have with people who have facial features is they do have moderate to severe presentations, but people without facial features just have a broader range of presentation. So they have mild to severe. And what we showed here with this is whether you're looking at autism as outcomes with or without facial features, whether a diagnosis is made or not, or with ADHD, the different types, there's very little difference between the overall presentations. The social communication questionnaire is a screening tool for autism alongside that. And you can see again, whether there's facial features or not, there's very little difference between them in terms of the overall scores. There's nothing significant, there's very mild. And so what you can basically say is that whether you have facial features or not, it doesn't define the severity. It's basically showing that. But what you highlight here is also it's really common, and you can see that autism and ADHD turning out to have a very high percentage overall in terms of our clinic and what we see. The next slide, if I move on, was looking at sort of whether or not postnatal adversity has an impact on this. And this is one of the things that we've been interested in for a long time as a psychiatrist. It always felt you either have to have trauma or you have to have a biological insult, and never the twain should meet. But actually, it's about how the two integrate and what are they doing in terms of the person who's sitting in front of you. The way I describe it, and I watch your Australian MasterChef all the time because it's the best one of the lot. And they do taste tests, and what you do is they give you something and you have to pick out the ingredients, and that's what we do effectively when we're in clinic. We have a person in front of us and we're trying to work out what's the biological part, what's the life experience part, what is all of these, and it's never an absolute of one thing or another, and we're trying to pull apart the different influences on that child or that adult's behavior. And so what we showed here was, if you are taken into care before or after 6 months, does that make a difference on your diagnosis, whether autism or ADHD? And the 6-month cutoff comes from the Romanian orphanage study, which is probably the most famous study of people being left in neglectful situations, where where you could see a difference in people's neurodevelopmental outcomes, and more likely to be autistic, more likely to be ADHD. But they also showed that if you were taken into care before 6 months, there was no difference to those people who weren't taken into care at all or left in the orphanages. And so that's why we use a 6-month cutoff. And what you can see again, no difference between that. And so what it's showing is that the biological impact that's leading to the presentation is prenatal in origin to a certain degree, and that postnatal adversity made no difference to the neurological outcomes. It's doing something different. It's not saying it doesn't do anything, but it's doing something different. So we have to look at pre and postnatal adversity in a joint manner to think about these effects and how they have that. And Liz, you led on the Nature paper that we wrote a few years ago now. I can't believe it's 2 or 3 years ago now. But that we talked a little bit in my bit of that about some of this in terms of the joint adversities that you can have, and how that is a compound effect, thinking about the vulnerability that these kids have and these adults have, how life then impacts them in a compound way. But from a neurological point of view, there's no difference when you're taken into care or those kind of factors.
Yeah, so that's an important message, that postnatal adverse childhood experiences do not count for everything. We really need to be cognizant of the prenatal alcohol exposure, which, as you say, has impacted the brain and hence function. That's a really
100%.
important point. And I think with the previous slide, it was also an important point that we can't equate those facial features, which really only occur in maybe 1 in 5 to 1 in 10 children with fetal alcohol spectrum disorder, with severity of neurodevelopmental outcomes. And that's not surprising, perhaps, because they are the result of exposure at a very specific time in early gestation. And we know that the brain continues to grow rapidly right through the 3rd trimester and can be impacted by alcohol at that time. So these are very important findings.
Just to come back just a little bit, so one of the problems that we have, and it wasn't until I realized, is that people used to get taught that facial features were the most important factor, and that it wasn't severe unless you had facial features, and that in a whole generation of physicians is what they have been taught. And so it's challenging that a little bit, to say actually the facial features are a useful way of actually identifying the alcohol exposure to give you an identity, but if you don't have them, doesn't mean that you don't have a severe presentation.
Yeah, absolutely. So, Raj, there are a number of new areas of understanding that sort of help us understand neurodevelopment in general, and also neurodevelopment in conditions like FASD. Would you like to tell us a little bit about some of these new ideas?
So what we're trying to understand is what is the underlying neurology that leads to this. So with neurodevelopmental field more generally, we're understanding that the networks of the brain are disruptive. And there's something between 7 and 17 different networks that have been identified in the brain. Most of the more newer ones are different frontal lobe pathways that they're starting to identify different things. So the brain isn't about parts of things working in isolation, it's about connectivity. I increasingly talk about FASD as connectivity disorder because it's about how the different parts of the brain are linked. And when you start to get to more complex tasks, that's when the brain really needs to be working together. And the salience network is one of those areas that's a really important one in terms of transitioning us from our basically what we call our autonomic nervous system functioning, which basically keeps us alive, keeps us breathing, keeps the general heart going, which the things that we don't pay attention to. And when we're sitting at, say, a set of traffic lights and we're just daydreaming, that's what's happening. Your default mode network is just keeping you in tick over. You're not having to really think, and you're daydreaming about other things. And so you're inattentive. Your salience network is a transitional network. It's a network that connects the different sides of the brain and links that autonomic reticular active system into your frontal lobes, which is a powerhouse of your brain, which is where your thinking, your organization goes on. If it doesn't work, you can have the best engine in the world. You can have a 5-liter engine or a 1-liter engine, it doesn't matter. If your accelerator's broken, you're not going to transition to it. You're going to have that ongoing tick over default mode network functioning, and your inattentive symptoms carrying on. And we know that people like Catherine Labelle in Canada have done and understood that there are salience network damage in people with FASD. And we know that that then leads to an increased likelihood of having inattentive symptoms because your default mode functioning will be greater. And so you can predict from somebody where you have FASD as a cause, because it causes central structure damage in terms, especially corpus callosum, which is a bihemispheric connectivity. The two sides of the brain, it's the big motorway, the big white matter tract from side to side. And we know that that's particularly affected. If that is damaged, you can predict that you're more likely to struggle to transition into frontal lobe functioning. So therefore, your inattention is going to be much higher. And that's what we see. We see people having much more like to have an inattentive form of ADHD if they have it than a combined type. You can have combined type, but inattention is far more common. And so you can start to think about what's going on neurologically as our skills, as our technology improve, and we can study this in more detail, we can start to say, okay, well, how does that relate to clinical presentation? And that's what we're starting to see effectively is things like the salience network, which is a bihemispheric connectivity, is linked to the central connectivity damage, which leads to how we understand the performance and the presentation. So clinically, you can start to predict this. What we need to do is to get better tools to allow us to use this in clinical practice, because putting somebody in a scanner, doing specialist tests is not always feasible. So that's the next step, is getting clinical tools that allow us to do this, to explore this in a different way.
Great. Thank you. Now we're sort of running, not short of time, but we probably might move on. And one of the key issues for us as clinicians is, you know, we make these diagnoses. How can we best treat and support these families? And I'd just like to take us through your approach to the management of FASD, autism, ADHD.
So the first thing to say is that it's always the individual who sits in front of you treat. You don't treat a generic condition, you treat the person sat in front of you. There will be indicators from understanding that condition that will guide you, but everybody comes with a different mix of presentations. We know that individuals with FASD, if they don't understand their own condition, if they aren't supported and they don't get help when they need it, are much more vulnerable. And so their mental health issues are also much greater. So we can see that historically it's been shown and continues to be shown that that if you don't get the right level of support, it's much more likely that they'll end up with some form of mental health issue, most commonly depression or anxiety. But then treating some of these other conditions, whether that through a holistic approach, medication, positive behavior support, thinking about how these integrate together to try and treat the different associated conditions. So if somebody's got ADHD, there's multiple consensus statements out there in the world. You've done them in Australia, we've done them in the UK, thinking about how we modify treatment to this group to get the best outcomes. The Canadian group have done that for psychotropic medication and arousal. So there's work out there that we can look at and say, well, look, this is an issue. In terms of their behavioral presentation, the PBS model, where do we use medication within that? Where do we use psychological interventions within that? And how does it all fit together in order to give the best overall for that person? And then we develop a plan that allows us to say, this is what kind of things they need, whether that's biological, social, or or social. So the biopsychosocial model is very much key to how we work in psychiatry, and very much what we would do to the management from a behavioral point of view of these individuals. The physical you deal with in the same way you deal with other physical situations, but in terms of that, it's very much a holistic biopsychosocial model approach.
Well, I think you've answered the last question of what special skills psychiatry brings to the field of FASD and, in fact, neurodevelopmental medicine. Would you like to make any comment on the differences in treatment and support for children and adults? Because you do work across the lifespan.
So the biggest thing that we find is the systems around the person change dramatically. The adult world, I don't know what it's like in Australia, but here in the UK, it's very much in the adult world focused around bits of you. And so you see you see the gastroenterologist, you go and see the neurologist, you see your GP about a cold, you see a respiratory specialist. You don't see a holistic practitioner. Even within psychiatry, you have different areas that we specialize in rather than looking at the whole. In pediatrics, there's more of a focus on the child. And so you see that person sit in front of you, you see the family, you see the other influence, you have a school system, which generally most kids will be going to school. So you have a system around them to fit. And in the adult world, you don't know what job they're going to be doing. You don't know what their social care needs are, their employment, their housing. They don't have families always around them to support them. So it starts to get a much more complex pattern of presentation that they need support with. The other thing is the law changes, is the law expects you at 18 to function. And you should be able to do what is expected of any adult post 18. The assumption is you can do that, and unless you're proven otherwise from 18 onwards, probably from 16 onwards. And so that becomes a real challenge for people where they've got these spiky profiles of being really good in some areas, but absolutely not in others. And so that causes confusion and difficulty in terms of all this. So there's a real challenge in terms of transitioning and understanding and explaining to people the levels of support people need. But if you put people support and you build on the strengths, you can really lead to some positive outcomes for individuals. But not without that, for some, there can be challenges as well.
Yeah, so there's that transition from pediatric to adult services, but also transition from adolescence to adulthood. And also in our setting, children coming out of home care settings at the age of 18. So Raj, this has been a really interesting conversation. We have lots of questions coming in, so perhaps we could start with the Q&A. First question is, you talk about midline structures being damaged. What is the research that tells us about plasticity and the chances that alternative pathways can be built in children with FASD to connect areas of the brain in the left and right hemisphere?
So the brain's always compensating, the brain will always develop, but bigger structures, the corpus callosum isn't regenerating. And so the really big areas of the brain, once it's damaged, it doesn't tend to, when we talk about plasticity, it tends to be more interneuronal connections in terms of how we restructure. And the brain is always doing that because that's how we lay memories, we do that's the associations we make, but it tends to be on a smaller level than the bigger gross pathology that tends to happen with this kind of stuff. So and so yes, the brain is plastic, but not to the extent that is needed to rectify some of the damage that's already been occurred.
Okay, next question. Am I right in saying that you are thinking that you said that prenatal alcohol exposure can contribute to ASD and ADHD?
Yes, because again, as I've tried to explain, ASD and ADHD are outcomes where the brain connectivity is affected, where so if you damage the areas that dealing with social communication in the brain, or the things that lead to rigidity, and there are models around this, mainly Bayesian mathematical models that people are coming out, and I don't like maths, so it drives my brain explodes with it, but there are new models that are coming out all around these. But if you damage and disrupt that, we end up with this condition that we've defined as autism. FASD is one of those disruptors, so it is the cause of the disruption effectively, and so that's how we look at it.
Thanks. Now, the next question's about prenatal methamphetamine. Some suggestion that exposure may have similar manifestations to FASD. Could you address whether it's possible to distinguish?
So my understanding of methylphenidate and the research around methylphenidate is it doesn't cause the neurological deficits to the same extent that we've had before. It does cause cardiac cushion deficits in terms of some of the physical aspects, but the longer term studies, same with heroin, didn't cause longer term ongoing deficits in terms of that. Research is always coming out. We may learn more as more and more people start to use it, but the usage so far hasn't indicated those long-term neurological damage. And so the general recommendations for methylphenidate that exist at the moment is that you should avoid it in the first trimester, and if you can avoid it during pregnancy at all, then great. But if you have to use it, then second and third trimester tends to be a safer way of using it.
That's what they used to say about alcohol.
Well, that's the problem, and this is what I was going to say, is that science moves on all the time, and there are more and more people using it. The thing with methylphenidate as a controlled drug, at least in the UK, it's a prescription medication. There's much more observation, much more regulation around it. Alcohol is something you can't go down and buy unless it's illicit. Go down to your corner shop and buy methylphenidate. It is very strictly controlled as to who can get it and how it's used, and it's prescribed. Whereas alcohol is freely available, and you can go down and buy 40% vodka or whiskey or whatever, and drink as much as you like, and that is a subtle difference, because the amount you consume can also have a big impact on the impact that you see on the individual.
Thanks. The next is a bit of a local question. Where can we refer adults with FASD for medical support in Australia, specifically Victoria? So I would suggest that you look at the FASD Hub and look at the guide to services, but also No FASD, our national organisation for FASD, has a helpline which may be able to help you find local services, and also has a service resource available. Now, the next question is, I'm interested in the motor skill problems in autism versus FASD. Is there a difference in the presentation?
So again, the question implies that autism is a singular thing. It's not. It is a broad spectrum of presentation because there's multiple things that cause it. And so if you have a cause that is disrupting motor connectivity as much as, then you will end up with situations where that dyspraxia, those kind of things will present. That doesn't happen in every case. So there are people who are autistic who have got very good motor control issues. In the same way, there are people with FASD who are very sporty, and others who are not. It depends to the extent of the damage, the disruption to the pathways that are going on. Again, if you think about it from a neurological perspective, motor control is something you develop with time. It is something where you have different connectivities between, again, maybe your left or your cerebellum and different other parts of the brain coordinating. But if those areas are not disrupted to the same extent, you won't have that presentation. And so again, it comes back to some people with autism will have dyspraxic type presentations, other people won't, because it's not a singular thing. FASD, again, it's variable. It's in terms of the extent of the damage, but there's loads of people with FASD who are very sporty, who are quite, yeah.
I think the expression goes, no individual living with FASD is the same as any other individual. Yeah. And I think that probably applies to autism as well.
Yeah.
Raja, the next question is, given the importance that you put to the damage of midline structures, what hope is there for imaging techniques becoming sensitive enough for diagnosis?
So at the moment, the problem is the Earth. Okay, and I'm being facetious a little bit, but the Earth creates a magnetic field. And so to get rid of that magnetic field, we have to put scanners in a Faraday cage, which is blocking off that magnetic field, which often means that you can't do typical everyday tests on the individual. And most of this connectivity stuff are deep structures. And so the type of tools that we can use, if we're talking about investigative products, are superficial. Until we can get a way of actually creating a room with a Faraday cage and with a cat or something that can look at deep structures, we're limited to MRI scanners. And MRI scanners are big, and they're very effective, and they can look at the whole brain, they can look at function, they can look at stuff, but you can't do much in them because you're restricted in what you can do. Anybody who's ever had an MRI scan knows how claustrophobic it is and how much you can't do in it. So at the moment, technology is limiting some of this. We have an understanding of where the deficits are, but we need technology to advance so we can actually be able to test this in real world settings. So Liz, you're sitting in a small room. I would want to have a scanner that I could take into the room there and scan what's going on whilst we test somebody. And until we've got that, there's going to be a limitation as to this diagnostically. It's a very much a useful research tool at the moment, and it helps us understand, but clinically, we need to have things useful in an adaptive manner that we can use in the room with the person at the time, and that's limited at the moment. And so technology needs to catch up.
That's good, because I don't think I want you coming in and scanning my brain this hour of the night, Raja. Now, this is the final question. Are there particular assessment tools or functional approaches that you found useful for understanding behaviours in young people with overlapping FASD, autism, ADHD and developmental trauma?
That's a really complicated question. There isn't one tool is the problem. It is a holistic approach to understanding. First of all, you have to understand what is going on. So the way that we would approach it is, step one, we would say, well, what are the neurological deficits that we see? What vulnerabilities does that create? Next thing we say, well, what is your pattern and profile of outcomes that we see? So do you have ADHD? Do you have autism? What extent of this do you have? What are your strengths? What are your weaknesses? And then we kind of say, well, what are your psychological difficulties and triggers on top of that? Where is your arousal in all of this? How do we describe that in terms of a PBS model is describing predictive and reactive strategies, understanding how they present, and then deciding how to intervene. So it almost becomes a behavioral management approach, which is biopsychosocial in its approach. And so then you're starting to say, how do we take all of this together and then predict what is going to happen, what the vulnerabilities are, what the response is going to be, and then put a framework around the individual to know how to do it. That's not one tool. Tools will help you. They will guide you to come to ideas around what the understanding. So if you look for ACEs, for example, for child experiences, they will give you an indicator of the severity of the difficulty, but it doesn't tell you everything. If you look at the brief, which is an indicator of adaptive executive functioning, it gives you indicators, but it doesn't tell you everything. So it's about combining these things together, getting that picture and profile of the person, especially the most complex individuals, and then saying, right, this is how we're going to manage it. And a lot of the time, the biggest challenge is then getting that implemented, because it's changing people's mindset from the person is not doing it because they don't want to, but because they can't, and that we have to change our adaptation. That is, so it's reasonable adjustments, but it's sometimes difficult for people to get their head around it. That's a cognitive distortion. It's a cognitive dissonance that people feel in terms of where they've been taught and where they're going to. And so it is a challenging approach, but there's no one set approach to that. It's about that holistic understanding and then taking that forward.
Well, thank you. That's just exemplifying the complexity of this issue and I guess illustrating the importance of a multidisciplinary assessment, and those of us who are lucky enough to have a multidisciplinary team. And I think also, as you've demonstrated, the importance of having a psychiatrist to whom we can refer our patients and seek advice, because it is extremely complex. Raja, you and I can exit the screen, but thank you very, very much for your contribution
You're
tonight.
more than welcome.